Hi, good morning, America. Good afternoon, Europe, Africa, and good evening, Asia and Australasia. My name is Napapong Napang, ISRT Vice President for Asia and Australasia region, your host for today's program. We are so excited to come back after a long holiday. And today we will run a very special program. And this is going to be first radiation therapy webinar from us, ISRT Facebook Live. And the topic of today is role of radiation therapists in patient safety on advanced radiotherapy technology. And more special for today is we have 4 panelists from across the world, both from us and from our sister organization and our friend organization. I would like to introduce first panelists. The first one, Charlotte Beardmore. She is the president of the European Federation of Radiographer Society, EFRS, and Charlotte is also the director of professional practice, the Society and College of Radiographers from United Kingdom. Charlotte, welcome you to our program. And the next panelist is my very good friend from Asia region, Dragon Liu. Dragon is the chairman of the Hong Kong Association of Radiation Therapists from Hong Kong. Dragon. And we have our Tan Chek Wee, ISRT Regional Director for Asia and Australasia. Chek Wee is the radiation therapist practicing in Singapore. Chek Wee. And of course, we have our president, Donna Newman, the president of ISRT, as the panelist today. And we also are very excited to have the 3 speakers to give you. I will introduce the speaker one by one with the topic and then give him the opportunity to present. The first one is Wilson Chung Hun Liang. He's the radiation therapist from Hong Kong Sanatorium and Hospital from Hong Kong. And Wilson will give a talk about MRI in radiation therapy, safety experience with the MR Linac. Please welcome Wilson Liang from Hong Kong.
Hello, everyone. Thank you for your kind attention, and thank you very much to the ISRRT, our hosts and the panelists for having me here today. Let me get right into it. The topic today I'll be going over how we've been putting MRI into our radiation therapy department and our safety experiences for staff and for patients while operating the MR Linac. So here's a quick rundown of the points that I'll be covering today. So MRI has been a very prominent imaging modality for many applications in radiation therapy for a very long time now. For many years, it's been mostly used as an image guidance tool for oncologists and radiation therapists to help delineate tumors, targets, and organs at risk. This is because of the superior soft tissue contrast compared to CT scans, and there's no ionizing radiation imparted to the patient. Much more recently, MRI has been increasingly used as a tumor tracking tool for real-time motion tracking and also for daily pre-treatment imaging. So with the expanded and increased use of MRI in radiation therapy, arguably the main concern would be MRI safety. Now, not only for our patients, but also for those who are operating the machines and for the staff around the department. So today I'll be sharing with you our own department's experiences while using MRIs, putting MRI into our regular RT practices, and more specifically our experience with the MR Linac and how we maintain patient safety throughout the department. So at HKSH, we use MRI very frequently and for many years because our oncologists usually use this modality to help with their target delineation. Usually this happens during our simulation procedures, and we get our patients to lie in the same position after getting their CT scan as well as in the MR scan. Up until 2 years ago, most of this was done with the help of our colleagues in the diagnostic department and with their machines, with some attachments such as like the flat couch and coils that don't touch our patients. The reasons for this is so that when we do image fusion between MRs and CTs, we can keep them as rigid as possible. But that was mostly in the past, and about 2 years ago, HKSH, we opened a new cancer center, and with that, an extension of our radiation department. So with these new facilities, we got a bunch of new toys, and that included 2 MR simulators and the first MR Linac to be installed and operational in Asia. Now, I won't go too much into detail about these machines themselves, but all of these machines are 1.5 Tesla, and the Elekta Unity is equipped with the 7MV Linac, and we can perform daily radiation while adapting using online planning. Now, the key to making sure that our patients are safe in an MR environment is to make sure that our facilities and our staff are well equipped and well trained to enforce MR safe practices. This extends to the entire department and not just for the operation of the MR Linac. But before going to more specific patient safety related concerns, I'll go over some of the concerns that our department faced when incorporating MR into the RT setting. Now, as you can imagine, having our own MRI machines in our own department, where MRI traditionally didn't exist, we faced many challenges. Luckily, we have a very well-equipped diagnostic department and colleagues who were able to receive additional MRI training to help us and guide us for the integration of MRIs into the department. Most of these solutions actually came from some existing protocols and established guidelines, such as the ACR guidance document on MR safe practices that came out in 2013, and a bunch of Joint Commission protocols that we borrowed points from. Now, in addition to adhering to these guidelines, we also want to foster good knowledge and good training for the hazards and safety management and for emergency procedures that might happen in this environment. So with the help of our medical physics colleagues, all of our departmental staff received live safety lectures, depending on how closely they'll be working with the machines. For our support staff and our cleaning staff, level 1 training was given, and that's mainly to help protect themselves and to maintain their own safety while being around the machines. On top of that, level 2 training was given to radiation therapists and nurses so that they can better support patients when they're getting their scans and when they're coming in for treatment. Our department also established an MR team, and that included members who have had more extensive training in MR, and those people have helped write a lot of the protocols and procedures pertaining to the MRI operation, its safety, and how we use the machines when they're in our department. Now, there can be many hazards when working in an MR environment, and too many to go over in a single webinar. So I'll cover a few of the main points that we try to make apparent to a lot of our patients. First of all, that is that the machine and the magnet is always on. Once the machines are ramped up, there's a static magnetic field around the machine, and it's constant until we decommission the machine or something like a quench happens. This also ties in with the existence of fringe fields that permeate around the machine for a certain distance, and any work within the 5 Gauss radius line can be especially hazardous. There are also 2 magnetic fields that are generated when the machine is turned on. The gradient field and the RF field. And these 2 fields are mainly are concerned for our patients because they'll be inside the magnet while we are using the machines. And these 2 fields can cause a lot of acoustic noise, and it's associated with a lot of the heating that occurs in the MRI. I'll also be going over some of the equipment that we're using, and I'll touch on cryogens in a bit. One of the big issues for incorporating MRI into the RT department was acquiring equipment and accessories that are largely non-ferromagnetic and can be classified as MR conditional or MR safe. These include very common items that you might find in a regular RT department, like wheelchairs and stretchers and patient monitoring equipment, like the pulse oximeters and blood pressure gauges. And all of those need to be MR conditional. Considerations for MR safety also had to be kept in mind when we were purchasing chairs and footstools, and also a lot of the small accessories that we might be using in or around the MR room, such as rulers and pens, and even down to the badges that we use that hold our door access cards. There's a spring inside those badges that can actually act as projectiles when close enough to the machine and has the potential to hurt our patients. For those of us who have worked with MR before, we should have seen pictures like these, where the MR and the magnet is able to pick up whole stretchers and wheelchairs. Sometimes we actually explain to our patients that the magnet's capable of picking up a small car. Now, we do that not to scare the patient, but to let them understand that all of the procedures that we go through and all the nagging about taking metal out from off their body is just to keep them safe. The last hazard I'll go into are the cryogens, and for the MR, that's namely liquid helium that's used to cool the magnet. For a regular MR machine, it holds about 1,700 liters of liquid helium to keep the magnet cool to a temperature that's very close to absolute zero. The purpose of that is that the magnet is a superconducting magnet and needs to be kept at that low temperature to maintain the magnetic field. In the case of an emergency, such as a fire or someone being pinned down to the magnet by a wheelchair or even a fire extinguisher, a procedure called the quench is going to be our last resort. What this does is it releases all the helium that is cooling the magnet, and it lets it boil off, and the magnet will quickly lose its strength and let go of anything that's being held by it. The main concern here is that helium has the potential to displace all the oxygen in the room, causing asphyxiation and cold burns to anyone that might be in the area. Another safety hazard is that the quench might also cause a large air pressure change in the room, and any of our door structures that aren't hinging the right way can effectively seal the door shut. So for therapists, the important thing here is to be able to distinguish the difference between many of the emergency buttons that we see in the control area and around the machine. Some of these reset the couch, some of these terminate the beam, some of these shut down the power to the machine, and there are some buttons like the quench button, which cost the hospital a lot of money. And we say that because it is used as a last resort and only in case of emergencies, because we'll have to replace all the helium and there's a chance that will damage the MRI machine itself. While safety training is one layer of the procedures that we use to protect our patients, another layer is the actual physical limitation of having patients being exposed to the magnetic fields. So back in the planning stages of our department and at the Cancer Center, an important part of the protocol was to map out our MR zones. Zone 1 is the general public zone where our waiting area is. Zone 2 is between Zone 1 and 3, and it's accessible to staff and patients who have checked in and are getting ready for the treatment. Zone 3, you'll have to get level 2 training, and you have patients and visitors who are coming in have to be accompanied by level 2 trained staff to be able to enter this area. And Zone 4 lies within Zone 3, and it's usually the machine room itself. So in our department, we have our simulation procedures and our treatment procedures on separate floors of the building. So we have two settings here. On the simulation floor, it's designed very much like a diagnostic department where we have our reception area in zone 2. Zone 3 is where our patients are getting ready, and zone 4 is where they get their scan. Where this differs is on our treatment floor, where we have actually multiple machines inside the zone 3 and not only the MR units. So in our zone 3 area, on the treatment floor, we have 2 machines, a tomotherapy machine and our MR Linac, and we also have one of our MR sims within that zone 3 area. At the entrance of every zone 3, we have wall-mounted metal detectors installed, and that gives us a quick evaluation of whether the patient or visitor or staff have any metal on their person. These detect magnetic field changes in the air, and so our patient and our subject has to do a little spin around to make sure to be able to be detected. For patients who have implants or are not able to stand up and move around, we do have handheld metal detectors to help pinpoint where exactly we might need to find something. So now let me take you through how a patient usually comes through our department if they're getting MR Linac treatment. Before simulation takes place, our first line of MR screening actually happens during their consultation with the oncologist. So the oncologist will usually let us know if there's anything of concern, such as implants and prosthetics or pacemakers, something that we need to be aware of when we're doing our simulation, and considerations that we might need to take before we bring the patient in for their simulation and treatment. We try to do the screening a day before the patient arrives so that we can have some time to find any materials that we might need to make, or contact other hospitals or other departments to make sure we have the necessary information to be able to treat the patient. I would say about 99% of our patients have a very thorough medical history, and we can usually find the make and model of their hardware, but sometimes the patient doesn't know any of that, and we do have to contact possibly the surgeon or the clinic that they got their procedure done to make sure that anything that we're bringing into the department is MRI suitable. Another point of note, most of our patients have had previous MRIs, but even though that's the case, we do our own screening and to make sure that we've covered all of our bases. Patients who are claustrophobic need to consider taking medication. Otherwise, they might be deemed unsuitable for the MR Linac treatment. Even if our patient can fit into the CT machine and the MR machine just fine, the MR Linac actually has a board that's just slightly smaller than our MR machine. And during the treatment, they'll actually be in the machine for about 30 minutes to 1.5 hours. So being in such a small space for such a long time can be pretty daunting, especially if you have claustrophobia. Our screening process here is a little different when compared to our usual RT practice, and it's actually a bit more complex and a bit tedious. So with metal implants or pacemakers, we can usually do a CT, and we do additional calculations to make sure the patient is safe. But with MR, we actually have to go a bit further with that safety. Any kind of implant that's not removable, like stents, hip replacements, spinal hardware, and dental work, we need to make sure that it's compatible with getting an MR. And a lot of those resources we can actually find using online or textbook resources like MagSource and Shellux safety manual to reference whether we can bring certain things into the MR. Some of these specific parameters are needed to be input into the machine before we can scan, and that usually helps with decreasing the chance of any twisting or torquing of the implant, and to keep the hardware at a very safe temperature for our patients. Pacemakers are of a particular concern because the magnetic field can interfere with the electronics of the pacemaker, and scanning could lead to heating, damage, and burns, and it could also cause irregular arrhythmia outputs, which are used to keep the heart beating. And in these cases, the manufacturer usually sends out a technician or a physician to help tune the pacemaker into safe mode before we scan, and then recalibrate it after we're done with the MR. Once a patient actually arrives at our department, we continue our screening procedures with our nursing staff and make sure that our patient understands that the procedures for simulation and for treatment are to keep them safe, and that they are not allowed to bring any ferromagnetic materials into the machine and have them on their body. So a lot of the everyday items that a patient might bring with them are often overlooked, especially if they're small little items like hairpins and hearing aids. Our patients who are getting MRIs need to be totally changed into hospital gowns, and that goes right down to socks and slippers, socks and shoes as well. And we give them slippers to put on. So we make sure that there's no metal on their body, no chance that there might be buttons or zippers that might be brought into the machine. For our planning purposes for the MR-Linac, we get at least 2 sets of scans, a CT scan and an MRI scan. And then depending on oncologist requests, there might be contrast injections for each type of scan. From the very beginning, while we do our CT, we have to put our patient into a position while taking into consideration the MR safety effects, and effects that heating and burning that might be caused while they're lying in certain positions. On top of removing all of the metal from the patient, we need to make sure that the patient isn't looping any of their limbs, and to reduce as much of skin-on-skin contact as possible, and especially around the underarms and between the legs. And all of the accessories that we bring into the CT scan are the same accessories and immobilization devices that we bring into the MR-Linac, and all of these are MR safe. There are additional immobilization devices that we use that are not provided by the manufacturer of the MR-Linac, and those ones we use in-house, and we make out of plastic or an acrylic and make sure that it's safe to be MR'd and dosimetrically acceptable. Treatment on the MR-Linac requires a very specific indexing for all of our accessories. So we do our best to reproduce that onto the MR simulator. At the MR simulator, we get a bunch of scans to act as a baseline scan for the treatment. And it's at that point where we determine whether T1 scans or T2 scans are more suitable for the localization of the treatment site. From our experience, abdominal and pelvic cases are generally better viewed using T2 scans, and T1 scans are usually for head and neck and cranial cases. So preparing for the MR simulation scan, there are a few more things that we need to consider. Firstly, it will be the hearing aspect of it. Acoustic noise is synonymous with the MRI because of the gradient field that creates that familiar thumping noise when you're getting an MRI. To protect our patient's hearing, we give them earplugs that can dampen the sound by about 29 decibels. And that brings it down to an average of about 80, which is considered safe as long as you're not prolonged exposure to the loud noise. While deciding what kind of earplugs we use, we actually had to go through a few kinds to make sure we have a good earplug that doesn't slip and fall out over time. For the MR scan, we have to place coils over the patient, and these transmit and receive RF signal to generate the image. These coils usually come with a very long wire, and we have to make sure that these cords don't loop around and they're not in contact with the body, because they can heat up and cause burns to our patients. One of the things we did do during our screening is we took the patient's weight, and we do that because it does come into consideration when we're calculating the specific absorption rate for the patient, and we try to limit our scans so that the SAR does not exceed 1 degree Celsius for the entire body during the length of our scan. Once simulation procedures are complete, the next time we see our patients is when they come in for treatment. For the treatment procedures, we maintain very much the same protocols and procedures for keeping our patients safe. But in addition to what we've done, to counter the acoustic noise at the MR Linac, we give the patient headphones. There's also the added benefit that we can play music through these headphones so that during the treatment, the patient doesn't get too bored. The MR Linac does come with a built-in feature that helps maintain our diligence to patient safety. We have to fill out a MR assessment form to make sure that everything has remained the same for our patient, and that we have to fill out this form before we're even allowed to load the treatment for the day. Our daily MR scans are usually done for pre-treatment, and usually we do an intra-treatment scan to make sure that the patient hasn't moved. And usually these scans are between 2 to 6 minutes in length. But the patient will be inside the machine, and they're inside the magnet for the entire treatment, and that can last for up to an hour and a half. We also continue with our safety protocols for hearing protection and contact precautions between the coils and the bore surfaces. So for larger patients, we usually wrap our patients up in blankets to make sure that they're not touching the bore in any way. Before we actually start the treatment and before we leave the room, we do a visual check to make sure that our patient is lying still, there isn't any wire looping, nothing's touching the patient, and that we're the last ones in the room. While we're outside the room delivering the treatment and doing our pre-treatment procedures, we have the CCTV system, and we have an active sound communication system to monitor the patient. The patient also has a call bell on them, so at any time if they need to get our attention, they can press the bell and communicate with us in that way. In case of patient emergencies, and if the patient is already inside the MR simulator or the MR Linac, our first priority would be to remove the patient from the MR environment, and removing them from zone 4 at least into zone 3. The machine couches can be manually brought out from the bore, and then we transfer the patient over to MR conditional stretchers, where we will perform our emergency procedures if needed. So in our department, we also have these emergency trolleys that can be brought over in case we need to, say, resuscitate the patient. Now, unfortunately, while we try to maintain our equipment to be as MR safe as possible, almost everything in this cart is definitely not. So that's why we have to remove the patient from the magnet before we administer any kind of treatment. On top of that, if there are any emergency staff from other departments, or say from the fire department that come into our radiation department, they are kept away from the machine because the magnet is always on. Now, lastly, to keep with the times and throughout this pandemic, all of our patients do have to come in with their masks, but with our standard face masks and our surgical masks, there's actually a wire inside that molds to our noses. We get our patients to remove that wire or to bring a mask that doesn't have a wire, so that helps keep them safe from the wire being pulled into the machine or any heating up that might occur of the metal inside the mask. So to summarize, incorporating MR into our RT department was no easy task. It took a lot of training, a lot of gentle reminders, and it's still an ongoing process to maintain and keep everyone aware of the hazards that exist in and around the MR environment. As therapists, we are always being very alert and keeping a very keen eye on everything that's going in and out of the zones and making sure that our patients are kept safe. And we're also keeping each other safe. So compared to normal radiation therapy standards, having a treatment unit within an MR environment is very unique. Not only in the therapeutic potential, which was not the focus of this presentation today, but definitely unique in the view that we have to maintain and continue establishing and advocating for patient safety. So thank you very much for your attention. Thank you to everyone in my department and the MR team for their contributions. And right, that's it.
Thank you very much, Wilson, for your very, very comprehensive talk. And it's eye-opening as an educator in radiologic technology, as we call it in Thailand. We three-in-one diagnostic, therapeutic, and nuclear medicine joining our program, and we are very happy. And I would like now to introduce the second speaker for today. The second speaker for today is Dr. Seiichi Ota from Japan. He's working at the Division of Medical Technology, University Hospital, Kyoto Prefectural University of Medicine. And the topic that Dr. Ota will cover for today is hypofractionated radiotherapy utilized with robotic radiotherapy system, respiratory motion tracking. Please welcome Dr. Seiichi Ota.
Good evening, everyone. I'm Seiichi Ota. Today, I'd like to talk about the hypofraction radiation therapy utilizing CyberKnife system, especially a respiratory motion tracking system. Before starting my presentation, let me introduce myself a little. I worked at the Osaka University Hospital from 2007 to 2018, and I work as a Red RTT, and I involved with several line commissioning, including a CyberKnife system. So today, topics are based on the experience in the former hospital. Here is today's agenda. Firstly, I talk about a timescale in radiotherapy, and next I explain about IGRT to correct interfractional variation, and then I talk about IGRT to correct intrafractional variation. It's topics about the CyberKnife system. And then finally, I summarize today's topics. And firstly, I will explain timescale of radiotherapy. Intro variation organ motion is happen during each single treatment, and It's caused by the internal organ motion such as respiratory motion, intrafractional organ motion variation, difficult to control and difficult to manage by IGRT without special equipment such as a cyber knife system. And interfractional variation is a day-to-day variation. We can check it by IGRT before treatment delivery. I talk about this IGRT before treatment delivery. It's an example of IGRT for correcting interfractional variation, and it's easy to evaluate and correct setup variation. And the left image is the orange one is a reference image, and the gray one is a convexity. You can see a residual error in orange box. We can easy to notice that. And when target visible in X-ray image, we can monitor target within the treatment field by cine mode. And next slide, I explain the limitation of CBCT and the prana images. And we take image before treatment, and from that result, we can correct position variation, and we can monitor a target within the field during treatment by cine mode. But it's difficult to correct after starting treatment. So it's difficult to correct intrafractional variation by CBCT or general prana imaging. We need special equipment to correct intrafractional variation. Cyber knife system is one of the treatment machines that it could correct intrafractional organ motion, and the cyber knife system detect and correct motion automatically in use of its unique IGRT system. Detected some millimeter deviation corrected by our robotic arm, and then deliver beam accurately. I will explain Excite Spine mode, its IGRT mode for our bony structure in cyber knife system. For bone-based correction, after taking image, IGRT system calculate to treatment position deviation to a reference image very quickly, typically within calculation time within 1 second, and a correct error based on the latest IGRT image. Typically, cyber knife system deliver the 3 or 4 treatment beam in every 1 minute, and we can adjust the imaging interval very easily. We took image every 20 seconds in the first 2 minutes after starting treatment, and checked patient position stable, which we change imaging interval every 1 minute. And we pay attention to a position deviation graph and its time trend, and detected a large error compared to a formal result. We show a shorten imaging interval or interrupt treatment. And next, I'd like to talk about the synchrony system, its main topics in this presentation. And I will explain a merit of target tracking mode, its synchrony mode. In left movie, you can see the conventional method to deliver to moving target. That cover a large area to irradiate to all range of tumor motion. In CyberKnife synchrony system on right movie, we can minimize treatment volume as possible. In synchrony mode, its tracking mode, robotic arm breathes with the patient. CyberKnife user often make a tracking demonstration like that movie. We took a CT image of this phantom and make a treatment planning. You can see there are very small beads on the phantom. We defined small beads as a target in treatment planning. You can see the laser pointer mounted Rhinac is indicating a bead target. That laser pointer adjusted to MV beam axis within the 0.5 millimeter. That demonstration allows us to check gross error does not happen. So we perform the demonstration as a daily QA. I will explain about a synchrony mode more. In treatment, we put LED marker on the patient's surface as external marker, and the LED camera capture the LED position in every 30 frame per second. So LED camera capture the LED motion in almost real time. When taking the orthogonal X-ray image, that imaging timing synchronized the LED motion and recognized the gold marker position linked to LED position. And finally, the two system LED camera and X-ray locating system generate a correlation model between LED position and gold marker position. It allows CyberKnife system to predict internal target position from external LED position. And CyberKnife arm moved according to a real-time LED position that linked to a correlation model between LED motion and internal gold marker position. But we often found the patient breathing pattern change. It led to a correlation model error. You can see the bottom of the graph is a correlation error. So we take a verification image after modeling, and the system compared the live marker position to the predicted marker position. That calculate from the model. We can check the model error easily, that graph, and pay attention to it during treatment. And to check the tracking error, we developed a software to check tracking error. You can see the CyberKnife system and the motion phantom. And here is a phantom we use as a target. We put small target beads on the cross line from the 4 black circle dot, and putting 4 gold marker on that phantom. And we take the phantom image by CT image and make the treatment plan for that phantom, and then move the phantom in several patterns of breathing to check the tracking accuracy of a CyberKnife system. And you can see the software function we developed. Web camera recognize the 4 dot and software define the cross line from the 4 dot as a reference position. It means the target position, and record Rhinac laser position and calculate coincidence between targeted cross line and laser. We can see the probability of coincidence here. Here is cumulative error of laser position related to target growth line. It means over 90% of error within 2 millimeters. We check two types of breathing pattern in this test. One simple waveform and other actual breathing pattern. I'd like to show result from a very simple sine wave pattern. All patterns show tracking accuracy was within the 2 millimeter. And actually, in use of simple sine wave form, the correlation error was almost no error. So it showed robotic arm response accuracy to LED motion was within 2 millimeter. And next, I will show result from actual breathing pattern. Here is the actual result from the actual tracking error from in actual breathing pattern. Error depend on the individual breathing pattern, but on this test, all error was within 5 millimeter. And accuracy of tracking for actual breathing pattern within the 5 millimeter, it including both robotic arm response and correlation model error. We mentioned about the robotic arm accuracy that was within 2 millimeter. So we set 3 millimeter as a tolerance of a correlation model error. In treatment, we pay attention and manage correlation model error being within the 3 millimeter as possible. For accurate treatment, we perform pre-check of correlation model error in same day of CT simulation. When we find over 3 millimeter correlation error, we remind to doctor and medical physicist that it might need additional margin for correlation error. In past experience, we found over 5 millimeter correlation error happened in the pre-check. In our opinion, for this case, it was better to ask patient to breathe slowly as possible for minimize correlation model error. And I'd like to share other tips in CT simulation and preparation for treatment. In planning, we make plan use of exhale breath holds image data set, but target location related marker might be different in inhale phase. Here is a superimposed image, inhale and exhale, and it's called marker center. You can see the target position deviation relate to marker here, and we should cover both CTV relate to a marker as ITV. And next we check the stability of marker position to tumor. Some marker might move from the initial position due to deformation of organ or filling digestive system. So we took a CT image again, at least before first treatment, to check the migration. It means marker position to target deviation acceptable. In our experience, it's typically within 2 millimeter. Some researcher report mean migration about 1.5 plus minus to 0.7 millimeter. And it's a workflow for a safer delivery to move target. In CT simulation, we check relation gold marker on target in inhale and exhale for ITV. And to check the correlation model error before treatment, so we perform a pre-check in the same day of the CT simulation. And to check gold marker position stability to target, we perform a second CT if we think need it. It's typically 2 millimeter. And in delivery, we check the correlation error within the tolerance. And it's a summary. What should we pay attention in tracking mode? And finally, I'll share the case of liver metastasis and I went with CyberKnife synchrony mode. Here is a dose distribution for liver metastasis. And here is a EOB enhanced MRI image. Enhanced area keep its cell function, so cells are still alive, normal tissue are still alive, and surrounding area of a treatment region here still enhanced due to accurate delivery. We should pay attention to several things for accurate treatment. Today, I share about some tips to safer CyberKnife treatment. Thank you for attention.
Thank you very much, Dr. Ota, for your excellent presentation. We got some questions for you later, and we will come back to you during the Q&A session. And the next and last speaker for today's program is Mr. Kim Tae-yoon. Kim Tae-yoon is the Chief Medical Dosimetrist at the Department of Proton Therapy Center at National Cancer Center of South Korea. And the topic that Kim Tae-yoon will talk today is the role of radiation therapists in patient safety in proton therapy. Now the program is yours, Kim Tae-yoon.
Hi everyone. Good morning, good afternoon, good evening. Thank you for taking your time to have this webinar. I also would like to give my special thanks to ISRT committee for giving me this great opportunity. My name is Tae-yoon Kim and I'm working at Korea National Cancer Center as a senior radiation therapist and a medical dosimetrist. And today I'm going to talk about the topic, the role of radiation therapist in patient safety in proton therapy. In 2010, the New York Times published an article about radiation treatment events, which soon raised the big issue about patient safety in the field of radiation therapy. In the article reported that about 94% of the events were related to the human error. And since then, many organizations established the programs about the patient safety. And in 2016, AAPM released a TG100 report on quality management. And it also tells us that the majority of the patient and safety events was related to the workflow or procedures that IT professionals are involved in rather than QA or commissioning. And for the past several decades, we have seen the field of radiation has remarkably advanced, which allows us to treat patients more accurate, more precise, and faster. But as it advances rapidly, it made us to work in a more complex environment. And computerized network system and automation technologies made us need more attention and effort in terms of patient safety. And those concerns can be even more important when it comes to ion beam therapy, that uses more sensitive radiation, mainly proton beam. And since 2010, the number of proton centers has been increasing so rapidly in the world. At the same time, the importance of the patient care in proton therapy is also increasing. So today, I'm going to talk about the key roles of the radiation therapist in proton therapy in terms of patient safety. And this is the outline of my talk. I will give you a general introduction of the proton therapy system with some key features about proton beams, and then I will talk more about a few key challenges that radiation therapists need to know about the proton therapy in terms of patient safety. And before summarizing my talk, I will also talk a little bit about the proton beam protection. And let me briefly introduce my hospital. The Korea National Cancer Center is the first cancer-dedicated hospital established in 2002. And it's also a leading organization in charge of many national cancer projects, including proton therapy. And we began the proton project in 2005. And after 2 years of construction, we treated the first patient in March 2007. And since 2015, we've been treating patients with a pencil beam scanning technique, which is the most advanced technique in proton therapy. And here is the layout of proton therapy system in KNCC. And the proton therapy system requires a large landscape of 66 meters in wide and 26 meters in depth. And the cyclotron is the key part of the system, and it produces 230 megavoltage of the proton beam. And the proton that leaves the cyclotron is transported into the beam transport line, which is connected to its treatment room. So here is a fixed beam treatment room is for mainly treating eye cancers. And the proton beam will be delivered through the rotating gantry, which is a huge structure that is about 10 meters high and weighs about 200 tons. And here is the proton treatment room with a beam nozzle and the robotic couch that can move 6 directions for adjusting patient setup. So proton therapy provides 2 treatment modes, the passive scattering and scanning mode. And passive scattering mode is a conventional treatment technique in proton therapy. And utilizes the scatterer to obtain a beam with larger field size. And in this mode, it needs many components to modify the beam, such as range modulator field to get the SOBP, and the brass aperture to shape the beam laterally, and range compensator to shape the beam in depth direction. And in contrast, structure of the scanning mode is quite simple. Instead of using scatterer, scanning magnets are placed in the beam path, and it controls the beam direction by changing the beam current of the magnet. And with this technique, we can directly use the tiny proton pencil beam from the cyclotron, and we can treat the patient with more advanced technology called PBS. So let's take a look at this video on how the PBS can deliver the beam to the targets. So you can see that PBS delivers the beam with a number of layers that covers the tumor volume, and tiny proton spots are placed on each layer. And by using this technique, we can achieve a true conformal 3D dimensional radiation therapy in laterally and in depth direction, so-called IMPT. And here is the proton's beam's characteristics. And the proton is positively charged particle, which is about 1,800 times heavier than electron. And it provides well-localized dose distribution in treating cancer patients. And here's a graph showing 2 different energies, photon and protons. While photon penetrate the patient body exponentially, the proton travels a relatively small amount of radiation at the beginning, and it gives all the energy at the end of its range. But the tumor has a certain volume, so we need to cover the target volume by adding additional pristine Bragg peaks, which is called SOBP, which is short for the spread out Bragg peak. And also, proton is much more sensitive for target movement or any changes in the beam path compared to photon. Only a little change can cause a significant dose reduction in protons because of the range uncertainties. And this is the key to understand in proton therapy. And in proton therapy, we hope that to make the best plan, but we always need to think about the worst cases as well. Otherwise, such a little change can lead the worst outcome. As you can see here, OER gets the dose even higher than targets. So in order for us to maximize the advantage of the proton therapy, we need to try to make sure that the proton beam is delivered to the tumor as safe and tight as possible. Well, yes, it's like we are holding the double-edged sword in the battlefield of the proton therapy. So there are basically three kinds of uncertainties in proton therapy. The first one is the range uncertainty. The majority of the range uncertainty comes from CT scanner in the process of the CT Hounsfield unit to stopping power conversion. And that's because proton interaction with matter is different from that of photon. And the CT imaging and calibration and CT artifact from high Z material also can be a source of range uncertainty. And secondly, the patient setup uncertainty. And interfractional variation can be reduced by using IGRT technique, but intrafractional variation can cause significant dose variation, especially in IMPT, because of the interplay effect. And any anatomical changes also need to be monitored during the whole course of the treatment. And lastly, the biological uncertainties. And the proton's RB is known as 1.1, but actually that is an average value. And in proton beam path, RB value is different along the beam. But the current TPS doesn't consider the biological dose, but only the physical dose. And this is another big concern in patient safety. So now let's take a look at what we need to consider for patient safety at each procedure of the proton therapy. The first one is simulation for patient setup. The treatment position must be reproducible and must provide adequate level of patient comfort. And patient immobilization device must be proton friendly, which means the most of the devices that we use for proton is made of carbon fiber. And we need to pay more attention to high Z materials and bowel gas near targets. And for that, we need to know general beam arrangement. And here is the example. Even the tiny surgical clip can cause underdose at the distal margin. And here is another case that whenever we see any high Z material in the image, we prefer to use the metal artifact reduction algorithm. And here's the case that we treated before. At the time we take the CT scan for this patient, we actually found that there was amount of bowel gas in the beam path, but the patient was urgent, so we had to treat the patient. And a week later, we took the CT scan for the verification, and we found that the bowel gas was gone. And this caused significant dose reduction to the targets, as you can see here. And for reducing the uncertainties and improving treatment quality, so many radiation therapists actually participate in developing homemade devices in our center. And this one is CSI board, and which is homemade and made of carbon fiber. And this can move in and out up to 40 centimeters. And we also can set up the patient with a spine position, not worrying about the proton beam uncertainty because it's made of carbon fiber. And for treating abdominal area, we also developed this rounded couch, and that allowed us to use the wider angle from the posterior field. And this can allow us to reduce the dose to the bowel area. And this is for the proton stereotactic treatment device. And well, proton treatment planning is the most challenging part in proton therapy. And ICRU report 78 describes that additional margin in that direction is needed to take into account for range uncertainty in proton therapy. So here's an example. We give the same margin to the PTB from CTB in photon, but in proton, the PTB margin has to consider its range uncertainty, which resulted in the different PTBs according to each field. And this modern TPS has the feature to generate the field-specific PTB by putting the value to a set of range uncertainty and set of margin and internal motion. And in this regard, the choice of the beam arrangement in proton therapy is also very important. In 2015, the ASTRO released the guideline for that. They're similar with photon, but different in selecting beam path. And usually 2 to 3 fields are used in many clinics, and more than 20 degrees of field separation must be made to avoid the skin dose. And this is quite important because proton doesn't have a build-up region. So if we treat the superficial targets, then, and actually in our clinic, we give even more than 20 degrees, usually more than 30 degrees are used to avoid a skin reaction. And beam orientation is chosen to have the shortest and the most homogeneous beam path. And this one is also very important. And the beam should avoid pointing toward the critical structure, at least 1/3. So here is the graph shows that the RB can go up to 1.7 at the end of its proton beam range. And this may lead unexpected result in this patient. And this is a case from our center. This pediatric patient developed an abdominal imaging signal near the brainstem after receiving the proton therapy. So once we set the appropriate beam angle, then we start treatment planning using inverse planning algorithm. But in proton therapy, it provides another algorithm called robust optimization, which takes into account for various uncertainties in the planning stage. And by applying that robust optimization algorithm, we can make the beam smoother and more robust in terms of range uncertainties. So you can see here the target is more robust. And after that, we again need to check the plan result with the DVH to see if it is robust enough or not. And those distribution also must be checked slide by slide. So if everything is okay, then we send the plan to the machine. Otherwise, replan is required. But in our clinic, but actually we do this process over and over until we get the better plan result, which takes quite a long time for planner to do this job. And for beam delivery, this is the basic treatment workflow. So we set up the patient and acquire the setup images and adjust the images through the robotic couch, and we start treating the patient. But for proton beam delivery, the imaging technology is very important, but due to the technical difficulties in IGRT in proton, because due to a heavy structure and complicated beam production process. And so IGRT in proton somewhat lags behind that of X-ray treatment. So let me introduce some key techniques that are available in nowadays. And the first one is orthogonal KV planar imaging, so 2D patient positioning. Although this is quite old one, but still the many centers in the world are using these techniques. And the modern proton therapy machines basically has this CBCT as a basic option. So it can allow us to have the 3D patient positioning, but poor image quality, so we can only check this positioning itself in proton therapy. And for some centers using a CT on rails or in-room CT to have high resolution imaging, and it allows them to have adaptive planning and treatment. And only some limited proton centers are using PET scanner and prompt gamma detectors. And this is only for the in vivo verification of the proton range, because we've seen so far that how importance of the management of the uncertainty, especially for range uncertainty, is very important. But still, there are many challenges to be overcome, such as a biological washout for PET scanner and bulky equipment for front gamma detector system. And this is the image of our machine. There are two flat panels detectors here for taking the orthogonal images. And every time before we treat the patient, we take two images of the patient setup and compare them with the DRR. And the correction is applied by using this robotic couch. And in proton therapy, the criteria for the setup accuracy is more strict, as not to exceed 1 millimeter in XYZ direction and 0.2 degrees of pitch, yaw, and roll of the patient. And CBCT also can be performed using these detectors, which is shown here. And what other factors affecting the patient safety in proton therapy? Unlike linear accelerators, a snout of the proton gantry nozzle is placed close to the patient's surface in order to reduce lateral penumbra. And in this process, the collision with a patient and machine may occur, which is we need to pay more attention to this event. And mishandling of the modifiers. And still many proton centers are using passive scattering modes that requires replacing brass apertures and range compensators. And since the weight of the brass aperture is up to 11 kilogram, so we need to be careful when handling the modifier not to drop it onto the patient. And monitoring patient is also very important as proton treatments takes time. So far, we've talked about the patient safety. So is proton therapy that uses 230 megavoltage safe for radiation therapists? In 2018, MGH Proton Centers of the University of Harvard released an interesting paper regarding the radiation safety for radiation protection, radiation therapy in working in proton therapy system. And the radiation therapists were divided into two groups, 12 RTTs for proton and 18 RTTs for photon, and compared the exposure dose rate over 14 weeks. And the results show that there was no big difference between the two groups. And RTT worked at the passive scanning proton system had more dose than RTT working at a scanning proton system. And that's because scanning mode produced less neutron. So this is my last slide. In proton therapy, there are many systems for the patient safety and radiation therapy safety. So in proton therapy, not only emergency button, but there is a search button which requires the last therapist who leave the treatment room to complete all checks and request the beam. And audible and visual indicators are installed for proton and X-ray on states. And during treatment, protons activate many components through nuclear interaction, which produce prompt neutron and prompt gamma radiation. And to reduce the radiation exposure, we wait about 2 minutes after beams off. And it's also important to reduce unnecessary exposure by keeping distance from the radioactivated material, such as nozzle and block apertures. We also wear a TLD badge and ring TLD. And here are the dosimetry for proton radiation therapists. And here is the block aperture and range compensators of the patient who finished the treatment should be also stored at least more than 3 months until they reach a safe dose level before disposal. Okay, this is my summary. The proton therapy system of Korea National Cancer Center was introduced, and proton therapy has led marked advances in treatment, mainly because of its excellent dose distribution using Bragg-Peak. However, proton therapy is more sensitive to uncertainties in treatment planning and beam delivery compared to X-ray treatments, and it requires more attention for patient safety. and patient setup and immobilization device need to be performed taking into account for robustness of proton planning and treatment delivery. For patient safety, the role of radiation therapists in proton therapy is becoming more and more important, and which requires having a better understanding of proton therapy system and constant effort. Lastly, but most importantly, as long as we can maintain the patient safety, proton therapy is very fun to work with once we understand it very well. So thank you for your time and attention.
Thank you so much, Tae-Yun Kim, for your excellent talk. And here comes the time for the Q&A. I think we have one or two questions for each, and then we will go to the panelists. Let me start with Wilson. Wilson, I got a very interesting question or comment from the audience. The question is about your training, because normally when you perform MRI scanner, it's for diagnostic radiographer, but you practice as radiation therapist. How did you get trained to operate the MRI?
So a lot of our training, we did a bit of in-house training as part of our program, but then a few of us in the RT department actually went overseas and got our training overseas and got certified in MRI.
Oh, I see. And another question is about what are the most common cancer type that your patient comes in for MR-Linac?
On the MR-Linac that we have right now, most of our treatments are for prostate cancer. The MRI is very beneficial to that because we're able to see exactly where the prostate is, the lymph nodes involved in that, and the seminal vesicles. And compared to like a cone beam CT or just orthogonal X-rays, it's very beneficial.
Oh, interesting. And then the next one is for Dr. Ota. The question is, if the marker migration is over 2 millimeter, is it a need to reposition or replan?
Yeah. Yes, it's need to replan when we detect the marker migration. And in cyber system, it's very hard to correct the relationship between gold marker and the target in the treatment session, because we define the relationship between the gold marker and target in the treatment session use of CT image. So it's very difficult to correct in a treatment session. So we need make a replan when we detect migration error.
Oh, I see. Thank you very much for your answer. And I think next question is for Kim Tae-Yun. Pretty much the same about the replan or retreatment. What if the patient has a change in the bowel gas? Do you have to replan or the treatment in the proton therapy?
Yeah, thank you for the great question. Yes, we do replanning for the case because as I mentioned in my slide, and this is very important to us to assess whether there are any anatomical change or any change that affect the beam path of the proton beam. So we actually recommend to take the CT scan regularly, and some cases, well, actually this depends on the doctor's request. Some doctors, if they think this patient is need to more, the CT scan more often, then we do the CT scan for the patient, and we decide whether we need to replan for the patient or not. But basically, yes, in that case, the replan is required.
Oh yeah. That's interesting because I don't practice in radiation therapy for a long time, but I know accuracy must be there. And I think it's time to go to our panelists. This is going to be a general question. Since most of you, three of you, practice in radiation therapy, what do you think about the future or the current trend of the advanced technology that we have in radiation therapy that impact our education and training for radiation therapists? Let's start with Charlotte.
Well, thank you very much, and thank you for the invitation to be here, and thank you for three brilliant presentations, just showing how the technology is really advancing so rapidly. And I think there's a real challenge in education, keeping a pace with the technological development. And I'm sure you see that in imaging as well. The training of the future workforce is hugely important. So changing curriculum and those education and training standards with the new technology is important. But then you've got to train the existing staff who are already clinical. And I think we've seen some good examples from Wilson, who said, he went overseas to get the certification in MRI.
Mm-hmm.
So I think we're going to need to cross-match much more closely with our diagnostic colleagues and learn. But there's no doubt the curriculum needs to keep changing.
Yeah, but because as an educator, first, I think the challenge quite a lot for diagnostic radiography, but for radiation therapy, I see the same trend because technology progress, and if you train just therapy and now imaging modality integrated into your practice, now the training, as a trainer, you have to take a look into it. So, Chek Wee, what do you think about this as the practitioner in radiation therapy?
Yes, as a practitioner, we are really struggling because there are so many new technology coming out. So even with IGRT and all the new equipment coming up, we are really struggling. So now even with the MR-Linac, with Proton, there's a lot of learning. And then currently, a lot of time, I think the problem we have is that it's always on-the-job training or either training provided by the vendors. So it's very difficult to get proper academic training like certification course or postgrad course in very specialized equipment. So even like Proton or maybe even like MR-Linac is very difficult to get very specialized training course program. So I think that is something maybe that we should be actually looking at. How can we better equip our radiation therapists or the practicing radiation therapists to have the necessary skill to manage all this advanced equipment?
Yeah, I do agree. And what about you, Dragon? You practitioner also in advanced place in Hong Kong.
Yes, thank you. I quite agree with Chek Wee because our advanced radiotherapy technique is very need our high imaging quality. Sometimes for the MR-Linac, we are in Hong Kong. We are trying to install in more hospital later. So it's also a problem for us to how to train our staff to have an MR operation experience. In my hospital, it's a government hospital, they plan to install the MR-Linac or MR SIM. They start to thinking of, they ask the diagnostic radiographer coming down to our department and coach our staff or have some short course to teach us how to operate the machine or how to operate the MR-Linac. And in the first step, maybe when we operate the machine, they will send some diagnostic radiographer and sitting next to us to help us to or assist us to do much more better. Maybe later on we also need to think any course or any training for our RTs colleague to have more advanced technique in this special imaging operation. Yeah.
Yeah. Before going to Donna, I would like to share as I'm the president of the Radiologic Technologies Board of Thailand, and we will take a look into this because our training is pretty similar to Korea and Japan, the East Asian model, where we learn for 4 years for all diagnostic, therapeutic, and nuclear medicine together. The good thing is the student can expose to all modalities across the 3 fields, but we face the big problem because the clinical attachment hour is very limited. We end up because only 4 years for our student, we can only have our student attached to radiation therapy for 4 weeks, and that's not going to be enough comparing to your one modality training system. There's a lot of debate in this. What we're gonna do? So what we decide is pretty much similar to Japan and Korea and Taiwan. I believe we are setting up the advanced certification for radiation therapists, so that on top of the standard curricula, they have 1 year certification for advanced radiation therapy practice. We are planning the curriculum now. We already finished the curriculum for diagnostic radiographers for CT, MRI, sonography. We did that already. And next step is for the radiation therapy. And back to Donna as the global representative of the profession. How do we look into this? Because radiography and radiation therapy training from place to place, we have huge difference. But at least for me and for you also, and also Charlotte, when we went to attend the meeting, as I mentioned before, at either WHO, IE, or other organization, we are questioned all the time, what is our standard for radiation therapists? What's your view on this, Donna?
Thank you very much, Napapong. I really think that I thank the experts for bringing forth the cutting edge technology, and radiation therapy is really on the cusp of showing exactly how technology is moving. And you probably are dealing with the advanced technology more than any other specialty area. But I think what we have to do as international and regional stakeholders is we have to work together and form a stance that we believe that there has to be some standardized education. We have to have the theory and the background for these different areas, whether we expand our education or formalized education, or we mandate that countries have to give staff time to learn this technology. I myself just installed a digital PET-CT. You come in, you learn this new technology, you have a week, and then you're on the floor doing patients. And that's just not enough time to transfer over in this multi-hybrid modality imaging and learn technologies that are not traditionally taught in an educational system in every country. So I think the best that we can do as stakeholders and leaders globally, regionally, and nationally is actually work together to have a stance that we believe standards need to be in place so that radiation therapists and any modality has the equipped time and the education to be up to states to treat their patients. And I think that's the best way to protect patients and to ensure safety.
Yeah. And back to Charlotte, what's your view on this? We need your view here.
I'm absolutely supportive of everything that Donna has said there. We need to work together. I mean, many countries are advancing at different rates, depending on the equipment and the access to that equipment. And you must see that across the ISRRT. We've seen fantastic innovation today and introduced very safely. Many countries are only just introducing IGRT. So we have to work together. We have to capture that intelligence, and we have to look to how we can optimize that development within that workforce. Absolutely. I think some standards across the world which will help all of us would be really welcome. And certainly from the European Federation of Radiography Societies, we'd be very happy and pleased to work with you in the ISRRT. We have a radiotherapy committee led by Anastasia Sarchasoglu, who's from Greece, I think known to you. And we would be very happy to work with you on that. I think it's an important area.
That's great, Charlotte. And I think here comes the time for the last comment from the participants, from the speakers. What would you like to say to your radiation therapist colleague all around the world from what you experienced so far in terms of your practice, standardization, and so on? Let's start with Wilson. What do you want to give a message to your colleague radiation therapists?
Because our field keeps evolving, I think it's very important that everyone keeps a childlike mind, keep learning, keep absorbing new things, making sure that everyone else is kind of on board with it and learning at a similar pace so that no one really gets left behind.
All right, thank you, great. Dr. Ota, would you like to give a message to the audience?
Thank you for giving me a great opportunity to speak today. I can share all my knowledge in the webinar so far. So if you need, I'd like to share my knowledge about radiation therapy. Yeah, thank you so much.
All right, thanks. And it's very great to have you here, Dr. Oda, because you practice both as the medical physicist and radiation therapist. It's the way you practice in Japan. And next is Taeyun Kim. You want to give a message to our colleagues from all around the world?
Yeah, thank you for giving me such a great chance. But actually, as I'm working in this proton therapy field, I feel that the boundary of the work in the radiation therapy and the radiation diurnal field actually is fading away as techniques are advancing. And where imaging technology is no more option in radiation therapy, it must have. And we have experienced some difficulties in operating with the proper imaging techniques. So we sometimes, or many times nowadays, we need to work together with diagnostic field radiation therapists, radiographers, and this is very important. And in terms of proton therapy, as the last year, as I mentioned in my slide, the number of the proton centers reached 100. And I believe the proton ion beam therapy is kind of a mainstream in the near future. So I think we, as the Charlotte and the Donna mentioned, and we is working together and establishing the proper program for education purpose for the existing radiation therapy is much more important. Thank you.
Oh, great idea. And you will have to be involved too, Kim. All right. And next, we would like to have Dragon Liu to say something.
Yeah, because coming in future, I think that radiotherapy is more advanced in imaging technique. So I encourage most of our colleagues to put more effort in learn some new things, especially for the radiation therapies. We more on maybe MR size and the proton planning and so many new techniques. And maybe in the future, AI will help us in some special area. As I know in the planning procedure, some AI procedure can help us to improve our procedure will be do faster. Can be done faster, maybe auto-controlling the organ at risk. And in future, maybe the AI may help us to take the imaging more accurately and for us to do the matching. The matching from the CT plan and the actual treatment imaging. Maybe the AI also can help us to more precise to find out the correct treatment area. So maybe we need to keep update the new knowledge, keep update more and more different, so many things we need to learn actually.
You give me a very, very good idea. One of our program next episode will be on AI in radiography and radiation therapy. And that would be a very good topic for us to run a webinar. Now it's your turn, Chekwe.
I think it's back to education again. So we need to review our curriculum in the training. Do we need to make sure that even if RT, because for Singapore, we are RT-based specific in education. So we got 4 years of RT education. So do we think we need to increase more diagnostic imaging component in our education? So there's something that probably we need to review. And not only imaging, we also need to look at AI. What about computer programming? So these are things that we are not familiar with. So when we are faced with AI, how are we going to manage this system? So that's something that probably we need to start looking at.
And Charlotte, final word from you. Great to have you here.
No, thank you. And I agree with everything Chekwe said, but in addition, I think we must look at team working. We must see how we still maintain the important patient care at the interface with that technology. It's so important, and that's the additional skill we bring. When 50% of cancer patients will receive radiotherapy at some point, we have a huge role to play, and we might only be a small profession worldwide, but the impact we can have is tremendous. So my last message is we must publish the research, we must publish the evidence, and I see brilliant speakers here today who've researched. Getting those messages out is so important through published academic research. Thank you.
Thank you, Charlotte. And now it's time to close the program by our president, Donna Newman.
Well, I want to thank everybody that tuned in and listened to our speakers around the world, whether it's morning, afternoon, evening, or late night for you. We are very blessed, and I can't thank our speakers enough. We've just demonstrated our great experts from around the world that have shared what best practice can look like in this new cutting edge technology. If you haven't had time to watch this now and you want to go back and take some notes from these speakers' great presentations, it will be on our Facebook Live page as a rerun, and you can watch it as many times as you want. I want to thank Charlotte, our EFRS newly elected president, for jointly joining us for our panel discussion. Your background and information was a wealth of knowledge. And thank you, everybody. Until our next Facebook page, our next Facebook Live session, we'll see you then.
All right. Have a nice day, everyone. Goodbye.
Goodbye.